Friday. It's not a Monday, but it
right?
probably should be.
Right? You're at? No, you're right. Okay, here we go, dudes. Here we go. All right. So why, in the first place, why learn about about the neurodevelopmental sequence, right? Why learn about this type of thing um, in the first place? Ultimately, right? The bottom line is that the reason why we learn about the neurodevelopmental sequence is because that is the foundation, right, of all rehab. Like I said, this is kind of a very laid back, potentially kind of goofy lecture, right? But the bottom line is that we go through a progression, right, of neurological development, right, that actually informs, um, obviously, not only um, how we develop movement patterns, right, but also how we develop muscular firing patterns as well, right? And so this is going to be really relevant when we talk, for example, about the lumbar spine, right? So as we age, though, we develop essentially patterns of movement um, that ultimately cause things like core musculature and other things essentially to become downregulated, right? And so ultimately, we go through a process of essentially substitution, right? Sorry, I hit the down arrow too soon. We start developing essentially substitution patterns in the way that we move, right? That actually compromises not only our ability to retain, right, stability, through core and these types of things, but um, also the way that we also obviously govern mobility and balance um, can change over time, particularly as we develop uh, muscular imbalances and preferences for the way that we move. Okay, so as far as motor patterns, right, we have to essentially kind of try to think about how it is that these motor patterns develop. Okay, so motor control. Okay, motor control is something that's essentially a very very closed loop. So let's say, for example, that we have, let's say, Bennett. Okay, Bennett is he's doing rehabilitation after a concussion, and he's balancing on an AirX pad. Okay, on a foam pad. Okay, because Bennett is balancing on a foam pad, right? The musculature essentially surrounding, let's say, Bennett's ankle. So calves, right? Tibialis anterior, peroneals. Okay, all of those things are contracting and firing rapidly to help him develop, or to help him maintain rather, balance. Okay, that that definition and that time frame for motor development and response is motor control. Okay, so conversely, though, okay, when we talk about motor learning, that's something that actually happens over the course, right, of a longer period of time. Okay, very often days, weeks, right, and even years in some cases, right. So um, obviously, motor development as we continue to grow and develop, takes place over a course of months or years, right. But as we talked about, okay, we develop essentially certain movement biases and muscular imbalances that can predispose us to not only injury but also uh, potentially even to prolonged functional impairment. Actually, okay. So before we go to the next slide, what do you guys think is an example of a pattern of substitution that we develop over time that essentially can inhibit normal movement? What's one example that you guys can maybe think of, or something that pops into your head?
Like an injury that doesn't heal.
Okay, so like say for example, you have an injury that doesn't heal, Bennett. How do you think that would affect movement patterns?
It's just like if it's gonna hurt or like if it doesn't heal correctly, you physically can't do it. Like, or if certain range of motion hurts, you're like not gonna
Yeah.
go there. You're just gonna have decreased range of motion until you deal with it.
Yep.
That
So
makes
for
sense.
okay, that's a great example. So let's say, for example, let's say somebody has maybe let's say they have a small meniscus tear, right? That they're choosing not to get fixed. Okay, so because they have a meniscus tear, they tend to want to limit their knee flexion, right? Uh, to essentially kind of decrease their pain, right? But in order to essentially make up, let's say they're trying to squat, right? And in order to actually make up the difference due to decreased knee flexion, they actually have to actually go into increased hip flexion on that side to be able to complete the movement, right? Does that make sense? So Bennett, your example is a good one. So ultimately, let's say if we were lacking, right, knee flexion, we would essentially substitute potentially with increased hip flexion to be able to um, perform the same movement uh, in the setting of decreased range of motion. Does that make sense, guys?
So your body compensating for the injury.
Absolutely, absolutely yes, absolutely yes. Okay, yep. Okay, here we go. Right. So how, okay, how do we typically develop from a motor perspective, right? Ultimately, all right, all of us obviously, we start off in this kind of in this prone position, and then eventually we're able to like hold our chin up, right? Now, what's the one commonality though that you guys notice anatomically? Okay, where do you think the vast majority of the weight is being distributed in these in numbers 1 through 3? Where's the vast majority of the weight being distributed? What do you think is supporting that the skeleton the most here?
The neck.
Okay, neck, and even so, neck, torso, and if we look at number 3, we can even see how the vast majority of that baby's weight is actually being essentially being distributed through the pelvis, right? So the pelvis is actually in contact with the floor, right? And so there are those who definitely have the opinion, right, that as we continue to develop, right, um, that essentially our scapula and also actually our pelvic bones are actually built specifically to distribute weight and provide support when we're laying prone and or even supine. So in these first 3 pictures, does this baby have a wide base of support or a narrow base of support? If you look at what's in contact with the ground, is that a wide base of support or narrow base?
I'd say it's wide.
Yeah, it's very wide, right? Absolutely, very very wide. Okay, so then obviously we can see that as muscular development continues, right, that base of support becomes gradually more narrow. Okay, so for example, we can see that they, starting to sit up, right? So the base of support goes from essentially the trunk and pelvis, essentially just to the buttock, right? And then obviously as we start to stand, we notice that obviously base of support becomes gradually more narrow as well. Obviously, moving from wider to more narrow, right? So obviously, as this baby develops coordination and muscular control, he needs he doesn't need as wide of a base of support to perform movement. So ultimately, what this picture shows us, right, is that this motor development it's first going to start at the head, right, and it's going to progress toward the toes, right, and will typically progress right from proximal toward the head, all the way obviously down toward the toes, right? Okay, so obviously, oops, sorry, next slide. So obviously, as we've talked about, right, ad nauseum, right? You guys know, okay, that there's obviously a trade-off between mobility and stability, right? So obviously, mobility is movement, stability is the ability to hold a posture, right? So our ability to obviously balance mobility and stability at any given point in time is motor control, right? And we remember that example from the shoulder. Okay, so for example, let's say that we have, um, kind of by way of review, let's say that we have a pitcher, right, who's got he's taken really really good care of his arm, right, and he's got a really really great balance between mobility and stability. If that's the case, what is happening there, okay, at the shoulder, if he's got really, really good motor control. What do you think the rotator cuff is doing in relation to the glenoid?
Keeping it centered.
Bingo, keeping it centered. Now, the same thing obviously happens, right? With even more simple motor tasks, obviously, such as walking and standing, right? Now, where we're going to obviously going to go this semester and continue to kind of uh, kind of dig a little deeper is essentially changes that take place neurologically that can essentially affect neuromotor control, right? Particularly when we talk about concussion, whether it's essentially maybe vertigo and or like changes to the vestibular ocular reflex, right? Or potentially more of a central issue such as cerebellar damage, right? Okay, station. We talked about this the first day, and we know, right, that station essentially is stance, right? So when we look at station, obviously we know that we need to essentially assess base of support, right? And we describe that as either obviously wide or narrow. Okay. So in the event, like we talked about, with someone that essentially has, maybe they have balance problems, maybe they have, myelopathy, maybe they're experiencing dizziness with vertigo. Um, how are they going to essentially adjust their base of support if they're having problems with neurological control? Well, pardon me. What would we expect to see?
They're going to widen their base.
Okay, yeah, they're going to widen their base to keep from falling over. Okay, absolutely. Okay, nice job. So ultimately, right, that posture and that stability serves essentially as almost kind of like a neurological vital sign for us, right? Uh, definitely gives us a window into the patient's functional status. All right. So, what about, okay, if we continue to essentially look at maybe even, you know, designing a rehab program, right? So every time that someone moves, okay, every time that someone changes position, okay, their center of mass, their center of gravity actually changes. So ultimately, the position of the center of gravity has a big impact on postural control. Okay, so for example, my center of gravity, generally speaking, if I'm standing still, okay, is located obviously right around my lumbosacral spine, generally between L5 and S2, right? So basically in my pelvis. Okay. Now, if I if I'm holding maybe a 10-pound weight and I lift my hands over my head, how do you think that changes my center of gravity? If let's say I'm holding 10 pounds, arms go up over the head, how does that change my center of gravity?
Wouldn't it rise with it?
Yes, absolutely. Center of gravity would go up. Okay, it would rise. Bennett, great. Why? Why would my center of gravity have to essentially go up or rise if I'm holding 10 pounds over my head? Why do you guys think that would happen? It's a great answer.
I don't know, but my gut told me that it would lower, but that just didn't make any sense. I don't know. Like I would have thought like it would have to lower to like make up for the fact that like just to balance you out, but I don't know. I have no idea why it would go up.
Okay. No, that's great. That's great. So
I have a theory.
you have a theory? Tell me about your theory.
Well, in order to keep the weight above your head, you kind of have to like be more stable in your like upper body.
Yeah, okay. And Izzy, yes, absolutely. Here's my question. You guys remember, right? When we talked about the shoulder in Tech 2, we talked about force. I'm sorry, we talked about torque. What do you guys remember about torque? We have a long lever and we have short lever, right? And torque okay, is the distance perpendicular, or is force times the distance perpendicular to the axis of rotation, right? So let me show you guys something, okay? Give me 1 second. Stay right there. All right, can you guys hear me? Good. Okay. Check it out. So yes, you're absolutely right. So for example, right now, my center of gravity is pretty much right here. Okay. Now, if I lift this 6-pound kettlebell over my head, right? Do I have more torque or less torque placed on me right now?
I'd say more
Absolutely, it's more, right?
because the
Okay.
distance is further, right?
Yes, absolutely. Okay. Freaking great. You guys are crushing it. Okay. So distance is greater, right? Therefore, I have more torque. Okay. And in order to essentially maintain motor control, right, I widen my stance and my center of gravity changes to keep me stable. Right? Does that make sense? Sweet. Okay.
So wait, one more time. Torque is the distance perpendicular to what?
So yeah, we cover. So we when we
Yeah, I know we covered it already.
That's okay. 1 second. All right. So I'll actually draw. I'll draw it for you guys. So okay, torque. Okay, torque equals force times the distance perpendicular to the axis of rotation. Okay. And so ultimately, guys, that's an equation. All that means for you, right, is the more force and the longer the lever, the more torque I have, right? I think that makes sense. And you guys remember the differences that we talked about between a long lever exercise and a short lever exercise, right? You guys remember those examples? Okay. All right. So don't worry. We will continue to kind of build this out, particularly as we talk about rehab for the spine, particularly, and concussion, actually. Okay. So perfect. All right. So obviously, when we talk about types of stability, guys, okay, there's obviously positional stability, right, which is obviously contiguous, which is obviously analogous to station and basis support, and then we have dynamic stability. Okay, which one of these do you think is generally going to be more necessary for athletic activity?
Dynamic?
Yeah, dynamic stability. Okay, going to be a lot more necessary for athletic activity. Okay, very good. Now, ultimately, right, when we are designing treatment and rehabilitation plans for people with neurological conditions, okay, whether it's back pain, whether it's concussion, whatever it is, right, we need to pay very close attention to stability, right? And so we always want to start with a position that has a wider base of support to ensure patient safety, right? And to ensure that they can obviously perform the task, and then progress to dynamic stability. So I'll show you guys examples of that as well when we get into rehab for concussion and the lumbar spine. Okay. So obviously, okay, we know that for stability, obviously sensation and proprioception are key. Do you guys remember? Okay, do you guys remember what what pathway our proprioception travels on anatomically? Who remembers the name of that tract?
Spinal thalamic.
Oh, close. Okay. Spinothalamic is sensation, right? So it's hot, cold. Okay. But remember, medial and meniscal is our proprioception. Very close. Bennett, that was close. Nice effort. That was good. Okay. So medial and meniscal system. Okay. All right. Okay. Transfers, right? So obviously, we know, okay, and as we learned, okay, transfers essentially involve, a patient changing from one position to another, right? So anytime that a transfer is normal or, doesn't have help or assistance, so no one has to help them transfer, okay, those are independent, right? Um, so ultimately, if we have someone that's using maybe an assistive device or someone has to essentially help them, right, get up, those are obviously uh, generally generally dependent or modified dependent transfers. Okay. Um, so in those situations, they may or may not use the hands. So for example, like we talked about, okay, if I go to stand up from my chair, right, and I do that without using my hands, okay, that's an independent transfer. Okay. So if I put my hands on the table and I stand up on my own, okay, that's an independent transfer with the use of hands. Okay. So so you guys obviously get the difference. Okay, between independent and dependent. Do you guys still have questions about that, about the difference between an independent versus a dependent transfer? Or is that, it's pretty cut and dry, right? Okay, cool deal. All right, so we're not going to spend a ton of time on this, guys. There are obviously different gait types. We don't necessarily have to spend so much time with these because we won't see these a ton. But I have linked, obviously, in the next slide, a video of various examples, right, of pathologic gait that you guys might see. Maybe not so much in the traditional setting, but if you work outside of the traditional setting, maybe you work in a clinic, you will definitely see some of these. Okay, so there are ultimately, hemiplegic, spastic diplegic, neuropathic, myopathic, right? Myelopathic rather, choreiform, ataxic, and Parkinsonian. Okay, those are just essentially for reference. But I've got a video here on the next slide, a link you guys can look at. It's also in the neurological learning resources folder on Moodle. Okay, guys, we're almost there. I know this is, we've got only a couple more slides left. Okay. So one of the things that you guys are going to see a lot, right, particularly when you have people that have like chronic problems, right, particularly neck pain, back pain, so on and so forth, right? Oftentimes, what we're going to be treating, right, are essentially chronic problems that are due to muscular imbalances, and a lot of times that's going to look like postural changes. Okay, so you can see, and a lot of us have this, where maybe we sit for too long at a desk, or we're constantly going to be looking down at our phones, right? Our shoulders start to round forward, and our neck tucks forward, right? And so this is an example of what's called an upper cross syndrome, right? And so ultimately, how do you guys think? So if you look at the picture on the left, okay, how do you think that you would essentially treat someone with this type of a problem? What do you think the goal is here in correcting this? What would you do? What do you think you would do?
You start by working hard with the neck and then work your way down.
Okay, yeah, well, that's good. Okay, so what direction do you think that you need to bring them into? Because if they're like this, okay, shoulders rounded forward and chin, and almost kind of chin tucked with cervical flexion, What do you think I need to do in order to fix that?
Correct their posture.
Okay. Okay. Yep. Absolutely, Drew. How would I do that? What do you think? Just what exercises do you think that you might choose to do that?
Maybe just some where they're trying to like squeeze their shoulder blades together or their scapulas together just to try and get those shoulders to not want to be rounded.
Okay. So scap squeezes is one. Also working on, and we'll talk about this later, but working on those deep cervical flexors. So chin tucks, funky chickens. Okay. Like that. Okay. So those are all excellent exercises. Okay. And then obviously, if we look over here at the right, on the right side, okay, this is an example of a lower cross syndrome. All right, where essentially we have developed really tight hamstrings and hip flexors, and so we have an anterior pelvic tilt, right? So we essentially have to re-lengthen and stretch these muscles to kind of get a lot of that length back, right? So, okay, guys, I know this is kind of a very basic PowerPoint, potentially seemingly random, but this is a way for us to essentially kind of begin to think about how we would apply, okay, some of these neurological principles to essentially rehabilitation, right? And these are going to essentially apply to things like back pain, right? Neck, the neck, right? And then acute post-op things as well, okay, in the later stages. So ultimately, right, there is a relationship between muscular activity, right, and the nervous system, in the sense that the more that we attempt to essentially reestablish a new muscular pattern, okay, we are essentially retraining and almost kind of resetting the nervous system, okay. And do you guys know? I don't know if any of you guys have met her yet. Have you guys met Claire Wobicki? She's a new instructor in the department. She's also go ahead.
Nutrition, right?
Nutrition, biomechanics,
Yeah.
and she and I teach research methods together. She's also an AT, and she's actually going. I'm going to give. There's as soon as she sent it to me, she's doing a lecture over what's called neuroplasticity. Okay, which essentially deals with how we retrain and how we can reteach the nervous system, okay, to do things. And so that's going to be essentially a bonus opportunity for you guys later in the semester, right? But essentially, there's a lot of parallels and essentially interplay between exercises, muscular activity, right, and retraining of the nervous system. Okay. Okay. So, guys, what questions do you have about this? Any questions at all? Was this pretty basic, pretty easy, or are you guys just like, yeah, this was actually kind of confusing? Don't really get this. Pretty easy.
Thought it was pretty easy.
Okay, good deal. All right. Okay, guys. Well, I appreciate all of you. I'm glad that all of you were here and present and accounted for. So, okay, guys, I will see you Monday. Don't forget, dress nice. Okay, we're gonna have some pictures. So, I'm gonna try to trim my face and look pretty. Maybe wear a tie, a little cardigan. You know, if anybody's needs a laugh today, you should YouTube the Dumb and Dumber scene where they're driving down the highway and the cop tells them to pull over. They're driving down the road in a giant sheepdog. And anyway, you can look it up. And the guy goes, pull over. And he goes, it's a cardigan, but thanks for noticing. And anyway, and you had to be there. You have to see it. But one of my favorite movie quotes of all time. But hope you guys are okay. Okay. And if you need anything, let me know. But I will see you guys on the Monday. Okay. Have a good weekend.
Have a good weekend, Wade.
Wade.
Thanks, guys.
Have a good weekend.
Thanks,
Bye.
Wade.
Bye.